Hello everyone. Today I will be discussing about the mucormycosis, commonly called as the black fungus disease. We will study it under the following headings: the introduction, in which we will see what are the common species of the fungus which cause this disease, and we will understand how this fungus gets access into our body. Then the risk factors, in which we will see who are at risk of getting this deadly fungal infection and what are the predisposing factors which can cause mucormycosis. Then the prevention part. In this section, we will learn how someone can keep themselves safe from getting this disease. Then clinical features, where we will see some unique clinical symptoms and also learn how the disease progress within human body. Then diagnosis part, that is how to diagnose it, what are the tests available right now. Then management part, if someone gets the infection, how one can manage and what are the options available. Lastly, we will go through steroid abuse in brief because it is one of the most important cause for mucormycosis in COVID-19 treated patients. Let us start with the introduction part. So, what is mucormycosis? Basically, it is an invasive disease caused by the fungus of order Mucorales and subfamily Zygomycetes, and it has species out of which the Rhizopus is most common over all the world, Apophysomyces, which is most common in India, then Absidia and Mucor. Though Mucor is most common in China, but it is rare over all the world. And in this picture, if you will look uh, here, this is the sporangium part. You can see this is the sporangium, and below this is the rhizoid part of the rhizopus fungus. Basically, this whole one is the rhizopus, this is the sporangium part, and this is the rhizoid part. Now, the term black fungus is actually a misnomer because this fungus doesn't produce any pigment, and the black color of the tissue that we see is due to the necrosis, thrombosis, and ischemic changes of the tissue. The fungus is ubiquitous in nature and present in soil. Its spores are present in air and dust. The common mode of transmission is through inhalation and by inoculation of spores on abraded or fissured skin. Then there is no man-to-man transmission, so you need not to worry if someone nearby you gets the infection, unlike COVID-19. Now let us see what are the predisposing factors which can cause it. Before starting, I would like to make one thing clear that not everybody who has recovered from COVID-19 is at risk of this disease. Then who can get the black fungus? So the first one is the immunosuppressed patients, because in them the phagocytic activity and antifungal activity of the T helper cells is lost. And why this happens in COVID-19 patient? This is due to the lack of immunity because of any malignancy like blood cancer patients, or in any solid organ cancer patients, say liver, kidney, or lung cancer, or in diabetic patients with the poor glycemic control and the steroid abuse. Then zinc overload is also mentioned as risk factor, but it is not proved otherwise. Then poor mask hygiene. People unknowingly use masks improperly, like using same mask for more than 3 to 4 weeks, or using a soaked mask. Ideally, a surgical mask should be maximally used up to 6 to 8 hours, and a N95 mask can be used for maximum 5 days, for say on alternate days basis. And that also in general public places, because if you are working in a healthcare facility, you should change it after your duty shifts over. So that is the mask, proper mask hygiene you should follow. Then the humidifier, which is used to humidify the oxygen supply through oxygen cylinder, is also claimed to be one of the risk factors. but it is less likely because this fungus doesn't grow in water. Like it can grow in damp soil, but not in any water bodies. Now, let us learn how we can keep ourselves safe from getting this deadly infection. The three cornerstone of the prevention of this disease is the sugar control if someone is diabetic, good personal hygiene, and reasonable use of steroid in COVID-19 patients. So basically in diabetic patients, a good glycemic control is a must. So we should keep a check on blood sugar level round the clock over 24 hours. And in personal hygiene section, we should use masks properly and avoid using same mask for long duration. I will repeat: surgical masks for maximum up to 6 to 8 hours, N95 at public places for maximum up to 5 days on alternate day basis. Then a better option could be a triple layered fabric mask, which can be reused after proper washing and drying in sunlight. Then we should use gloves and wear full sleeves cloths while handling soil and take a proper bath after that. Lastly, in COVID-19 patients, steroids should be used cautiously as it can also increase their blood sugar levels. Now, let us discuss some of the clinical features of mucormycosis. Basically, what I have done here is divided the disease in its subtypes, and we will see the clinical features in each one of them. And this flow chart basically tells us also about how the disease progress in human body. So let's start with the first one, which is rhinocerebral mucormycosis, which is the most common subtype. And as the fungus first involves your nasal sinuses, and from there it invades either into the orbit or the CNS, and it presents with the features like headache, retroorbital pain, facial swelling and numbness, toothache, or loosening of teeth. And in this picture, you can see the orbit is involved, the maxillary sinus is involved, the nasal mucosa is involved, and once you open the mouth, you will see that the palate is also involved. From there, it can gain access to your lungs, which presents as pulmonary mucormycosis, and the symptoms, it has the chest pain, fever, hemoptysis, which is blood in cuff, and this is the image. This is the CT image of lungs showing pulmonary mucormycosis. Then once it's within your circulation, can also affect the GIT, called as the gastrointestinal mucormycosis, which presents with symptoms like nausea, vomiting, pain abdomen, hematemesis, which is blood in vomit. Then it can also present as cutaneous manifestations, which occurs either through direct invasion by the sites like IV cannulation sites or from the sites where tapes are used for securing the endotracheal tubes, and it presents with ulcers and necrosis, can involve your muscle, fascia, and bone also. And then lastly, the disseminated type, um, which means the fungus is scattered throughout the body and it involves most commonly your brain, the other organs, the other parts are the other parts it can involve are trachea, mediastinum, kidney, peritoneum, and bones. And in this slide, basically, it tells you how the fungus invades through your capillary walls. So this is a slide of capillary, blood capillary, and the arrowheads are showing how the fungus invades through the capillaries wall. That's all in the clinical feature section and the disease presentation. Now we will learn how we can diagnose this disease, mucormycosis. So first of all, we can use 10% potassium hydroxide wet mount to see the hyphae and to differentiate it from other fungus. We can use the lactophenol cotton blue mount, which we will see in few moments. Then culture techniques are also available. And the Sebrod agar medium is used most commonly. The biopsies and histopathological examinations are best for definitive diagnosis. And the RT-PCR is also available but not routinely used. And samples for specimens are scraping from lesions or by a surgical or endoscopic debridement if the lesions is somewhere inside. And bronchoalveolar lavage can be used for pulmonary mucormycosis feature patients. And the sites for the sample collections could be the lesions of orbit, nasal mucosa, palate, sinus, or within the lung. So in this picture, basically, this is the picture of histopathological slide, and which is stained with the PAS stain, which is most common used and is best. And you can appreciate the aseptate hyphae making branches at right angles. So you can see here in this aseptate hyphae, the branch is at right angle. Here also you can appreciate, here you can see. So this is an important feature to differentiate it from aspergillus, which are septate one and makes an acute angle branches. Then we can see in the lactophenol cotton blue mount where these blue ones, these blue ones are the sporangium, and they have attached with the long, slender, ribbon-like structures, which is a characteristic feature of mucormycosis. And these ribbon-like structures are more reliable features than the angle of branching for the diagnosis of mucormycosis. So this is basically a picture of rhizopus stained with lactophenol cotton blue. That's how we can diagnose the mucormycosis. Coming to the management part, once you diagnose it and confirms that it is mucor, to know the extent of disease, we can go for CT or MRI. And in this picture of CT head, you can see the paranasal sinuses are involved, the orbital tissues are involved. So CT and MRI can help to know the extent of invasion of the infection, and obviously MRI is preferred over CT scans, and it particularly tells you about the extent of invasion and progression of disease. Coming to the treatment part, it requires a whole team of specialists to manage the disease, as the multiple different body parts are involved. Like we need microbiologists and biochemists to confirm the diagnosis first. Then dentists are involved if your teeth are involved. Then ENT surgeons, ophthalmologists, neurophysicians, and neurosurgeons are required to manage the rhinocerebral type of mucormycosis. Internal medicine specialists, nephrologists, and plastic surgeons. Intervention could be required if it invades into your lungs, kidneys, and cutaneous structures. In the medical management, we have a limited choice of antifungals, with that is amphotericin B, which is the drug of choice for mucormycosis, and this totally changes if it is aspergillosis. Hence, it is important to differentiate between them at the earliest. And amphotericin B has high toxicity and less CNS penetration, so we can use the other version of it, which is liposomal amphotericin B, which is less toxic and has better CNS penetration. Then we have the other option of liposomal amphotericin B lipid complex. Then the caspofungin and posaconazole can be tried, but they are not encouraged due to the lack of too much clinical data. So that's all about the management part. Now we will discuss in brief about the topic steroid abuse, which is considered one of the most important cause for mucormycosis. And so, what I want to convey through this picture that use of steroids should not be generalized. Uh, and in this and this meme is about last year around June, scientists found that the steroids are working good and is able to reduce mortality. But that doesn't mean that everyone who gets COVID should necessarily get these steroids. And if you do so, you will end up like this in June 2021. So we should follow the guidelines properly, and when we should know when to take it and how much to take it. Basically, steroids are found within our body from the adrenal gland, from the cortex to be specific, and it is synthesized from cholesterol and plays an important role in metabolism of fat, calcium, protein, carbohydrates, and in water excretion. It has actions like anti-inflammatory and immunosuppressive. So I have decided to divide it into two parts, like what we should do and what we should not while using the steroids. So let us discuss the not part first. We should never use it in mild cases of COVID-19. If you know the classification of COVID on the basis of symptoms as mild, moderate, and severe, it's good. If not, then you can see my previous video. Then we should avoid the use of steroids in first week of infections, like in starting 5 to 6 days. Then a higher dose of steroids are also discouraged. Preferably, longer duration use are also discouraged, and we should be like super alert while we use it in diabetic patients, in peptic ulcer patients, patients with history of hypertension, tuberculosis, chronic heart failure, renal failure patients, and many more. Like we should cautiously monitor them and should assess the risk benefit ratio and then decide whether to use it or not. Now in two part, if you know when to not use it, it becomes quite easy for you to predict this part. Obviously, it should be considered in moderate to severe cases. Then can be started from second week, like from 8th or 9th day of the infection if the condition of the patient is deteriorating and oxygen demand is increasing, and while using a low to moderate dose is preferred always, and it should be tried for maximum up to 10 days, and if it is required for more than that, like in ICU patients, while we are withdrawing it, it should be tapered gradually. So that's all we should know about mucormycosis for now, and hope you all like the video. For more content like this, please do like, share, and subscribe the channel. Thank you for your attention. Stay healthy, stay blessed. Goodbye.